We're going to go ahead and get started. And Dr. Binkley, you are starting this evening. So if you would go ahead and share your screen.
All right. Thanks, Diane. Thanks, Rowan. Can you see my screen?
Yep.
Yes?
Yep.
Okay, great. So I'd like to share with you the 2020 AACE postmenopausal guideline update. As Rowan mentioned, both Joe and I are old and curmudgeon-y, and so I can't just share an update without giving you some editorial commentary. So some of this is clearly my opinion, not the AACE clinical practice guidance. When you see the orange text color and or this orange rectangle in the slide, that is my shorthand for this isn't AACE, this is my opinion. These are my disclosures. You're all well aware of the osteoporosis crisis, and basically it's when we do nothing, patients fracture. This is a nice little study from, I believe it was Roanoke, Virginia, of a number of patients who presented to the ER with an acute vertebral fracture, and they were then followed for 2 years. Within 2 years, in these roughly 3,000 patients, there were almost 1,400 new fractures. Said another way, roughly 4 out of 10 of these folks sustained a new fracture within 2 years of their incident vert fracture. Data that I'm not sharing with you from this study basically said we did nothing. About 1 in 20 got a calcium and vitamin D recommendation, about 1 in 20 got their bone density measured, and about 1 in 20 got offered an osteoporosis drug. So you're all well aware that we're not doing well. It seems logical to me that uniform and clinically applicable guidelines should be helpful to improve osteoporosis care. And we've got way too many guidelines, and they don't agree. I went to guidelines.gov and entered osteoporosis guidelines. I was rewarded with 10,000 records. PubMed, when you enter osteoporosis guidelines, you get 3,400 results. And even on the IOF website, we get almost 100 different guidelines. How is it that doctors and patients cannot be confused? Now, it seems logical that guideline harmonization might actually improve osteoporosis treatment. That's not just my opinion, but it's the opinion of others, as you see here. And amazingly enough, Mike Lewicki was able to lead an effort to come up with some basic bullet points in Mexico, the United States, and Canada regarding core principles for osteoporosis treatment. In the interest of time, I'm not going to read these to you. I frankly think it's amazing that we were able to get 3 countries to agree on anything. But this is, I think, a step forward, and I'm going to point this out, that the basic paradigm here is to say maybe we should be using fracture risk to guide pharmacologic therapy. A nice quote from Mike is that all guidelines are wrong and some are useful, and I actually think the AACE 2020 update is indeed useful. The citation is here, Pauline Camacho et al., Endocrine Practice. When you see no citation on these slides, I'm referring back to this publication. So here's the highlights of the 2020 update. It's the expanded diagnosis of osteoporosis, guidance regarding clinical evaluation and fracture risk assessment, fundamental, i.e. non-pharmacologic measures for bone and fracture health, when is drug therapy indicated, updated the treatment algorithm to include ROMO, and discussed considerations in sequential use monitoring and treatment success. Very briefly, what is osteoporosis? This is my bias. This is what osteoporosis is. And this was the NIH consensus almost 30 years ago now. You're all familiar with it. It is loss of density and loss of quality or microarch. The AACE guidelines speak to 3 different definitions of osteoporosis. The first, the BMD T-score classification that you're all familiar with. The second is osteopenia and elevated fracture risk using FRAX. and the third is clinical osteoporosis with a low trauma fracture independent of BMD. So basically, in addition to the tissue level diagnosis, we have these three clinical ways to diagnose osteoporosis. I wanted to share these data with you that were just published from Manitoba, and it basically indicates that when our patients fracture, their bone is not normal. And this, I think, does support treating.
I'll be back later.
All right, so this is the relationship of bone status with incident fracture, with prevalent fracture. It looks the same. We define normal bone as a T-score of negative 1.0 or better and a normal TBS. And if you just look here, any incident fracture, what proportion of these women have normal bone? And it's virtually none. So overall, in these 2,500 women with fracture, 4% had normal bone with this definition. Over age 70, it was less than 2%. And with hip fracture, it's virtually nobody. So this, I think, indirectly does support recommendations to treat with a fracture without BMD measurement, but it's my bias, we need BMD measurement for monitoring. This is probably a US-centric recommendation. The title of this slide says it all. The diagnosis persists even if the BMD gets better. And I'm sure that all of us have run into situations where we want to use drug X, we can't because the patient doesn't have osteoporosis. This is just AACE coming out and saying, here's guidance that says keep the diagnosis even if the BMD improves, just like hypertension. There's no change in DEXA indications. Indicated in those at increased risk for osteoporosis and fracture and willing to consider treatment. These are the same indications that you have seen previously. I will be sharing with you a couple slides about the Osteoporosis Canada guidelines that are in process of being revised. And they are suggesting that perhaps we should be using FRAX without BMD to decide when to perform DEXA. Not going to go through the data in detail, but this is what this paper concluded, that if you have no clinical risk factors, doing a DEXA at age 70, if you have one at age 65. Should we be measuring BMD at menopause? I think that's an interesting consideration. The guidelines do not speak to that. There are data now that in addition to, you all know that women rapidly lose bone around the menopause. We know that. TBS also declines by roughly 1% per year. These are data from SWAN. And so I think you could argue that maybe we should be measuring bone density at menopause, but are you going to act? Here's a 50-year-old woman, no clinical risk factors, T-score -2. In the US, her MOF risk is 5%. And when we measured BMD, DEXA quality matters. This is not part of the AACE guidelines, but there are these recommendations, the AACE consensus statement on DEXA quality that basically says, doc, you need to look at the actual scan images. My bias that if you're not doing that, you can't provide high quality osteoporosis care because DEXA errors are so common. No change in the spine imaging guidance. T-score worse than -1 and older age, historical height loss, prior vert, or prednisone use. So nothing new there. But these data, again from Osteoporosis Canada, raise the question, should we be doing VFA all the time? I've highlighted the number of women and men needed to screen, 8 and 4. Again, the guidelines didn't go there yet, but maybe we should. Something to think about. So summary of the new recommendations regarding risk assessment and diagnosis: evaluate all women over age 50, history, physical, and FRAX, BMD testing as noted. If you're using BMD, DEXA needs to be done and it needs to be done well, and 3 ways to diagnose osteoporosis. Non-pharmacologic, calcium, very briefly summarized, shoot for 1,200 milligrams from diet plus supplements if needed. Dietary might be better. Total intake not greater than 1,500, and the role in vascular calcification is controversial. Vitamin D, AACE is still sticking with the 30 nanograms per mil, but acknowledging that other groups recommend 20 nanograms per mil and feels that a reasonable upper limit is 50. They are, in fact, leading the field, I believe, in going over to D3. So they're saying treat with 5,000 of D3 daily for 8 to 12 weeks if you are deficient. Rarely do you need 50,000. Typical dose, 1,000 to 2,000 IUs, and use D3 rather than D2. Why? High dose is not physiologic. We cannot produce 50,000 units from our skin. Maybe high doses are associated with falls risk, or maybe not, but that's at least out there. Intermittent bolus dosing might increase 24-hydroxylase, i.e. increased degradation. And the guidelines say some 25D immunoassays may not accurately detect D2. My bias is that they do not accurately detect D2. And that's going to give you a spuriously low value if you're using ergocalciferol. It's time to get away from ergo. Fundamental measures, basically what I said, plus the things that we all know and do: limit alcohol, active lifestyle, falls risk, PT. There is a new algorithm out there. There's the AACE 2020 treatment algorithm. I'm not going to try to go through that in any detail. Pharmacologic therapy recommendations really have not changed. Osteopenia plus prior fracture, T-score -2.5, T-score of -1 to -2.5 with the MOF of greater than 20 and HIP greater than 3. What medications to use? You can read that as well as I can read it to you. They do come out and recommend, in essence, parenteral therapies for people at highest risk. Romo was added. I'm not going to go through the Romo text in any detail at all. I'm sure you're all familiar with romosozumab. This, I think, is an advance from the guidelines, and that is to say use anabolics or dual action agents as initial therapy for patients at very high fracture risk. What in blazes is very high fracture risk? Here is some guidance, largely expert opinion based, but fracture on treatment, multiple fractures, drugs causing harm like steroids, high falls risk. And here's some concrete numbers. Recent fracture within a year, T-score less than -3, MOF greater than 30, HIP greater than 4.5. I think that's helpful. I think it will be helpful in arguing for anabolic agents for our patients. When you're considering very high risk, this is not the clinical practice guidelines, but recognize that fracs can be adjusted. High dose steroids, we increase the fracs calculation by 15%. With the lumbar spine BMD offset, it's 10% per T-score. TBS is automatic adjustment via software or web. Type 2 diabetes, you can use the RA button. And importantly, recency of fracture. Here's data out of Iceland that says with a fracture in the prior 2 years, you multiply the frac risk. Here, you up it by 15% or 10%. So 10%, a 10% 10-year risk with a 10% increase would be 11%. Here, this is a multiplication. This is dramatic. So in this instance, a 10% risk in a 50-year-old becomes 25%. These are data from Iceland, needs additional validation, but this was published by the IOF group. It speaks to the importance of treating after a fracture, and indeed, IOF is emphasizing what they are calling imminent risk and arguing to use anabolics over anti-resorbatives in that setting.
5 minutes.
Thank you. Other than this very high risk, AACE did not address when to treat. That's exceptionally difficult. Should we use T-score? Should we use FRAX? Should we use hybrid? Should we use FRAX and T-score? I just point this out to you if you want to obsess about this. This is an incredibly scholarly work that Leslie published, where they looked at 17 potential strategies and evaluated each of those with 19 metrics, and in Canada concluded that what they are at currently, which is treat at an MOF risk of 20%, that wins. I don't know if Osteoporosis Canada is going to come forward with that, but I think they might. Be aware that if you're just using a T-score of -2.5, you're treating people with radically different fracture risk. People will argue that the RCTs support treating at a -2.5. That's true, but RCTs also say we should treat osteopenia here with zoledronate, or we should treat women with normal bone density here with denosumab. So the fact that the RCTs show reduction at -2.5 is not a strong argument that that's the right cut point. The guidelines, again, haven't changed much, but don't be amazed if we change to fracture risk calculations in the future. That won't be happening in the short haul in the United States. Monitoring, monitor with DEXA, 1 to 2 years until stable. Consider bone turnover markers. There is verbiage in the guidelines about markers. I'm not going to go through them this evening. I do want to share this slide with you that documents in our evidence-based world, here's evidence that monitoring DEXA improves adherence, and unsurprisingly, the time to fracture is delayed in women who had a monitoring DEXA. How long to treat? Not much different here. Consider a holiday after 5 years if the risk is no longer high. Continue up to 10 if it remains high. Remember that there's a rank order of the bisphosphonates for bone binding affinity, with ZA greater than alendronate greater than risk. My bias, do no harm. Consider how the bisphosphonates increase BMD. Most of it is filling the remodeling space. You get this transient bump. 25 years ago, Haney argued that there's a positive remodeling balance. I have immense respect for Bob Haney, but I think he was wrong here. I don't think we are overfilling the remodeling space. And in fact, with alendronate and with zoledronate, we do not increase wall thickness. Bisphosphonates are not anabolic. And therefore, I see little reason to continue administering these drugs. And I believe that bone physiology argues for a shorter treatment time. And clearly, AFF goes up really quite dramatically somewhere around 5 or 6 years. So consider being less aggressive regarding bisphosphonate duration. What is successful treatment? This is defined in the guidelines. It's basically stable or increasing BMD with no evidence of fracture. Again, a single fracture on therapy is not treatment failure. So this is what I've tried to go over very briefly in 20 minutes, and I thank you. Diane, are there any questions?
Neil, this is Paul. I did have one that I sent to Diane, but I'll ask it. Those guidelines applied to postmenopausal women, but how do they apply to men?
Great question, Paul. They don't. The guidelines are clearly focused on postmenopausal women.
Okay, sorry, I'm having a few technical issues here, and I know there's also one more question. If I can, the person who asked the question about the 55-year-old woman monitoring, could you please unmute your line and ask your question while I troubleshoot this?
Yes, hi. We many times run into younger postmenopausal women with official diagnosis of osteoporosis based on DEXA and not interested in treatment or skeptical, no other high risk for fractures. So, and they've had a repeat bone density test, numbers are stable. no falls or other high risk. So is it okay to monitor? How do we convince them, or how do we convince ourselves that they need to be treated?
Well, at the risk of sounding really cavalier, move to Canada. And by doing so, you would not be treating that woman. In 2010, the Canadian guidelines came out and recommended treatment at an MOF risk of 20%, not at a T-score. And I think that many osteoporosis experts are taking that identical approach in that the woman that you described who's 55 with no other clinical risk factors, she's going to be at an extremely low risk for fracture. And yes, she has osteoporosis, but no, she's not at high risk for therapy or for fracture rather. And I think many of us would not give her drugs. That's why I pointed out the discordance, if you will, of the current of our current guidelines that says treat at a T-score of negative 2.5 or worse. But if you happen to be negative 2.4, then you've got to have an elevated MOF or hip risk. Those guidelines are not internally consistent. So personally, I don't have a problem not treating the 55-year-old woman with T-score osteoporosis, but low frac risk. I don't think the US guidance is going to get there in the short haul, but I think that the long term, that's the way we're going to go. That would be my bias.
Thank you so much. That's very helpful.
Okay, any other questions? We have one more in chat. In patients with wrist fractures, is it the same degree of impact of BMD TBS similar to vertebral fractures or hip fractures?
Well, great question. Classically, the answer to that has been no. I believe that the impending, and the AACE guidance didn't speak to that. I believe that the forthcoming NOF guidance is going to push for including wrist fractures as an osteoporosis-related fracture. I think that is likely correct.
Neil, this is Paul, can I comment on that? There's a recent paper out in the orthopedic literature that looked at the incidence of spine and hip fractures after a distal radius fracture, and the risk was 3.5 times higher, which to me really suggests that those patients should be evaluated and potentially treated to try to prevent the next fracture. And they usually occur, at least in on the bone database, in patients 10 years younger on average than a hip fracture. So to me, they're just a hip fracture waiting to happen.
And Paul, I agree with that. And I think that if indeed the Iceland data on this multiplication of the frac risk is borne out in other data sets, that's basically going to say that those women need to be treated with an anabolic. That's going to be a sea change of the way that care is given. I think we need to sit and wait. But if that finding is replicated, it's the young women who are at the massive risk for the next fracture. So it may well be that we should be treating those women and treating them really quite aggressively. Stay tuned.
Okay, we have one last question. I have seen data suggesting increased fracture rates during drug holidays. I have not seen data providing the drug holidays are truly safe or proving the drug holidays are truly safe or effective. If drug holiday, in quotes, were a drug, I do not think the FDA would approve it. Are there going to be any large drug holiday studies looking at safety and efficacy of the drug holidays?
No.
What is the best fracture data that you are aware of in terms of drug holidays?
No. Ken Saig spent about 3 years trying to put together an NIH proposal did a great job, and I believe was subsequently told not to submit the grant because it was going to be too expensive. Pharma's not going to do this. You know, the data that we have is not great, and I think it's unlikely to get better.
Okay, thank you.